Okay, good evening, everybody. So, thank you for joining today. So, we will start the questions now. Okay, it's already 8:15. There was a technical problem, so we couldn't really start on time. So, let me share the questions now. Yeah, so like before, you have 2 minutes per question. Okay, you can start now. Okay, I think the time is enough. So we'll go over the discussion now, okay? Right. So before we start the discussion today, I thought I will tell you some things about the final exam now because we just finished the exams in clinical. So I don't know whether you heard anything from your seniors about the exam, but there are a few things that I need to tell you. One thing, make sure that you pay an equal amount of attention to your clinicals. Okay, everybody is more concentrated on the MCQs, saying like MCQs and the SCQs, saying theory, theory, theory all the time. It really doesn't matter how much you know theory when it comes to the clinical exam. Okay, and another very important thing that has been brought to our attention recently through the extreme hard work of our Dean Madam is that your clinical exam marks are as equally important as your MCQ marks when it comes to the common merit list. So it's no longer just the MCQ marks, your clinical examination marks are very, very important. Okay. Doesn't matter how well you're performing your MCQs, if you don't do well in your clinicals, your merit position is going to go down. So one thing that I would tell you, do not make the mistake of asking for a longer study leave. Because the longer the study leave, the poorer the performance is in the clinical exam. You can ask from your seniors, they will tell you because we warned them when they ask for a longer like study leave, asking to cut down on the revision last 4 weeks of the prof appointment. We warned them this is going to happen. And now they have realized that is one of the things that had gone wrong because the exam was prolonged because of like the New Year holidays in the middle and everything. And on top of that, they had a very long study leave because the last 3 weeks of the prof appointment was cut down on their request. And the study leave was too long and people have lost their clinical touch. Some of the techniques that some students used in the short cases, like during the examination, I was appalled. I was like ashamed to say, I was embarrassed to say I have taught these students. Sometimes it was that bad. Okay, so I don't know where these newer techniques are coming from, whether somebody is giving you cookie classes or whether you all are watching videos which have incorrect techniques. I don't know where things are going wrong. But consistently, people are using wrong techniques in the examination. So I would warn you, because you have about, I think, 11 months to go until your exam. Practice from now on. Because if your technique is wrong, you are not going to elicit signs. If you palpate for the spleen in the epigastrium, you are not going to palpate the spleen. Even when the spleen is palpable, you are going to miss it because spleen does not stay in the epigastrium. Okay, so spleen is there in your left hypochondrium, not in the epigastrium. So something as simple as that. And like if you don't perform the correct maneuvers during your cardiovascular system examination, you are not going to hear the murmurs. Okay, so you can't at the end of the day say, "Oh, I forgot to do that maneuver. I would like to perform the maneuver." No, it doesn't count because you should have performed it during the examination, not afterwards. Okay, so the bottom line is pay as equal attention to your clinicals as you pay to your theory. Otherwise, things are not going to go very well. The way you touch a patient, we can say how experienced you are in like handling a patient, how experienced, like whether you have been to the wards at all, we can say just by the way that you handle a patient. So be warned is what I will tell you. Right, so we'll move on to the questions today. So the first question, true or false type. Which of the following is are causes of liver cirrhosis? The first answer, viral hepatitis B. Okay, what do you think? True or false? Yes, good, that is true. Then viral hepatitis A. Okay, almost all are correct. There were a few wrong answers. Viral hepatitis A is false. It does not cause a liver cirrhosis. Okay, so viral hepatitis A and hepatitis E, excuse me. Right, sorry about that. So viral hepatitis A and hepatitis E are like known to cause an acute viral illness. So they do not lead to chronic sequelae. Right. So if I ask you, can viral hepatitis B cause acute viral hepatitis? Hepatitis B, can it cause acute viral hepatitis? Good. Yes, it can. Okay. The majority of cases of viral hepatitis B are actually acute viral hepatitis. Only about 10% of the hepatitis B infected patients will go on to develop chronic hepatitis, not everybody. So 90% will resolve. 10% will develop chronic ongoing viral hepatitis. Okay, so remember, hepatitis A and E are only acute syndromes. They do not have a chronic viral hepatitis. Hepatitis B can be acute as well as chronic. Okay, hepatitis C. What about hepatitis C? Do you get an acute viral hepatitis or is it a chronic viral hepatitis? Or is it a combination? Anybody? Hepatitis C. Is it an acute hepatitis, chronic hepatitis, or like in hepatitis B, is it a combination? Okay, many say it's a combination, but no, it's a chronic one. Okay, hepatitis C is considered a chronic viral hepatitis. Hardly ever so. Like if you go through the Harrison's, it says there can be acute viral syndrome, but it's extremely rare. It's extremely rare to the point that we consider hepatitis C only as a chronic viral syndrome. It doesn't really have an acute phase. Okay, so it's a chronic liver infection, usually detected when the patient has already developed cirrhosis. Okay, yeah. So next one, cystic fibrosis. True or false? Okay, some had answered. I would say those who didn't answer, good job, because I told you at least one of the the 5 answers is going to be a difficult one. So rather than risking it, if you don't know, it's better to leave it unanswered. Okay, so cystic fibrosis here is the difficult answer, but this is true. Okay, it's not a common manifestation of cystic fibrosis, but it can be present. It can lead to liver scarring and cirrhosis. Okay, so the answer is true. Hypothyroidism. Okay, no answers. I guess this would happen because when it sounds so weird, too weird, I would say, you would think, okay, am I missing something here? But no, hypothyroidism is not a cause. Okay, so sometimes you will get very weird answers like this. So hypothyroidism is not a cause. This is false. Okay. Next one, alpha-1 antitrypsin deficiency. That is an easy one. Alpha-1 antitrypsin deficiency. Yes, good. This is true. Okay. Right. So these are causes of liver cirrhosis. So of the answers given here, viral hepatitis B, cystic fibrosis, and alpha-1 antitrypsin deficiency are the correct answers. So the lesson to learn, if you are good lateral learners, if you are lateral thinkers, you are going to go and like find out what are the other causes of liver cirrhosis, other common causes and uncommon causes of liver cirrhosis. It's up to you to read. Okay. Right. Next one. A 39-year-old male is diagnosed to have hypertension. Which of the following statements situation? Okay. A 39-year-old male. This patient can be defined as having young hypertension. True or false? Okay, not many answered this question. I don't know why. The majority of the ones who answered are correct, but the others are wrong. Few other answers that are wrong. This is true actually, because for you to say young hypertension, the age cutoff is considered to be 40 years. Okay, anybody who has hypertension less than 40 years of age at onset is considered to have young hypertension. Okay, right, which brings me, which reminds me, so this time again, we had a few patients given for the long cases with myocardial infarctions, ischemic heart disease. And in the long cases, when I asked the presenting students, is there a family history, positive family history? And some said, yes, there is a positive family history. But then I asked, is that a significant family history or not? So this is a family history of myocardial infarction. So not many knew how to answer that. So what do we mean by asking whether there's a significant family history of myocardial infarction? What is the meaning of that question? Did you understand the question? So when you have a patient with acute myocardial infarction, when you go through the history, and like you will come to the family history eventually. So you ask the patient, do you have, like, is there anyone in the family who has had like acute myocardial infarction? And they would say yes. Okay. So how do you know whether this is a significant family history or not? Yeah, I'm getting a few answers. So one says sudden cardiac deaths. Yes, sudden cardiac deaths you have to ask about, but that alone does not make that a significant family history. So they have a greater risk than the general population. Now, this is what I'm asking. What would put them at a greater risk than the general population? The reason being, these days, the like myocardial infarctions, also non-communicable diseases, NCDs are so common, so common. If I ask any of you, do you have a family history of like myocardial infarction? If you really think, I'm pretty sure more than 90% of y'all will have a family history of acute myocardial infarction. But that really doesn't put you at a higher risk than the rest, just like having a positive family history alone. The reason being, like, people live to a much riper age nowadays compared to before. So as you age, age is a non-modifiable risk factor for acute MI. So compared to maybe about 40 years ago, when the average life expectancy was about 60 years, now it's about 76 in Sri Lanka. So 76 years, okay, after about 70 years, a lot of people are going to get MIs. So is that really significant? Does that really increase your risk of having an MI? Not really. So dam sara. So yeah, that is true. Younger age MI. Okay, so there are few like who have said that, yes, young onset MI, that is one. And M1560 has said if it's a first degree relative. Exactly. So first degree relative, Sachindra, you're also correct. So first degree relative having a MI at a young age. So can somebody define what do you mean by MI at a young age? Because this is what we were getting at. Because you need to know how to risk stratify a patient. So what do you mean by MI at a young age? So the physician who was like co-examining with me asked these questions from many students. Not a single one was able to answer. And I was surprised why you don't know that. Okay, so the homework today, you are going to go and find that out. Okay, go and find that out. What do you mean by a young age of MI? Because for this, for both genders, there is a difference. For females, there is an age limit. For males, there is an age limit. Okay, because females and males, the risk of MI is different. Okay, the risk of MI is different, probably because of the hormone. So after menopause, male-female risk becomes equal. Okay, so you are going to go and find out what would you define as a young MI or a significant history of myocardial infarction in males, and how do you define the same in a female? Okay, so that is going to be one of the homeworks. Right. So young hypertension is hypertension with the onset less than 40 years of age. So yes, this patient does have young hypertension. So the first answer is correct. Next one, the commonest cause of young hypertension is primary hyperaldosteronism, otherwise known as Conn syndrome. So it is true. Okay, there is a mixture of answers, but I would say the majority of the answers are correct, which this is false. Okay, the commonest cause of young hypertension is not primary hyperaldosteronism. Can somebody tell me what is the commonest cause of young hypertension? So it's not primary hyperaldosteronism. So what is it? Renal disease, hypothyroidism. Okay, any other answers? LVH, hyperadrenalism. Renal artery stenosis, PCKD. Okay, any other answers? Good, finally somebody got it. Chamara. It is correct. Okay. It's essential hypertension. Lamai. Okay. Even of the young hypertension, the commonest cause is still essential hypertension. I'm not asking here what is the commonest secondary cause of young hypertension. No, I'm asking what is the commonest cause of young hypertension. So even for young hypertension, it doesn't matter whether it is young hypertension or old hypertension or whatever. For hypertension as a whole, essential hypertension is the commonest cause. So what do you mean by essential hypertension? It's idiopathic. Okay, so you can't find a cause. So can't find a cause or essential hypertension is the commonest cause of hypertension regardless of the age. Regardless of the age. So why do we talk about this something called young hypertension? So if you take a patient with hypertension, it may be primary or essential hypertension, or it may be secondary. Okay, secondary means, okay, there is like any of the causes that you all have mentioned here. Renal artery stenosis, polycystic kidney disease, CKD, Cushing's, hyperadrenalism. So all these are like secondary causes of hypertension. So any is possible. However, it's about the relative likelihood. Okay, why we define this age of 40 years and less is because the younger the age, the more likely that the patient will have secondary hypertension. But more likely doesn't mean more than 50%. Okay, so even at the age of less than 40 years, only 10% of the patients will have a secondary cause for hypertension. 90% of the patients will still have essential hypertension. Okay, so let me write that down. Okay, so you have patients with hypertension, okay, which can be either primary or secondary, right? So whether it is primary or secondary, like what is the likelihood of a patient having a secondary cause for the hypertension? So if you take the older people, old meaning I would say over 40 years of age, majority of cases, the majority of patients will have primary hypertension or essential hypertension. Right? So this will be more than 98% of cases. So that means only about 2% will have a secondary cause for hypertension. Right? However, if you take the younger population, that means less than 40 years of age, the likelihood of having a secondary cause for hypertension is 10%, which means essential hypertension in 90% of cases, a secondary cause will be found in 10% of the cases. Okay, so now compare the figures. So in the older people, secondary hypertension, secondary cause will be seen only in 2%. Whereas less than 40 years of age, a secondary cause will be seen in 10%. However, less than 40 years of age, still the commonest cause of hypertension is essential. That's primary. Okay, so remember this. Even in younger hypertension, the commonest cause is essential hypertension. Why you investigate them is, whereas in an older patient, the likelihood of having a secondary cause is only 2%. In a younger patient, the likelihood of having a secondary cause is about 10% or more. Okay, and the earlier that you detect this secondary cause, the better the reversibility. Because if the hypertension goes on for too long, even when it is secondary, and then later you find the cause, you go and correct the cause, the hypertension will not reverse. Can somebody tell me why? Now, say for example, this like you have a patient, say with hypothyroidism leading to hypertension. Okay, because as you all, like some of you all have said, hypothyroidism is a known cause for secondary hypertension. So say there is a patient with like hypertension secondary to hypothyroidism. So this has gone on for about like few years now. Even if you diagnose and correct the hypothyroidism, the blood pressure does not return to normal. Why do you think this happens? You have learned all this in your physiology. You are not just connecting dots. Good. Somebody has given an answer. Arterial wall changes. M1570. Yes, hypertension-induced vascular damage. Yes. So what is this vascular damage? What does it do to the arterial walls, to the vessels? Imagine your like circulation like a high pressure plumbing system. Yes, good. So there is intimal thickening, because if the like in the plumbing system, if there is too much of pressure inside, the pipes have two options. They can either burst or they can be replaced by a thicker pipe, thicker pipe. a pipe with a thicker wall so that it does not burst. Okay, because these are not vessels that can go on enlarging and enlarging and enlarging. Okay, so what happens is the intimal thickening. So intimal thickening ultimately leads to increased peripheral vascular resistance, a total peripheral resistance. Okay, and this total peripheral resistance increases the blood pressure, because our famous equation, you know, blood pressure equals cardiac output into total peripheral resistance. If the total peripheral resistance goes up, the blood pressure will go up. And this arterial sclerosis is something that is irreversible. So you can't do anything about it. So that is one reason. Another reason is there can be secondary organ damage, such as renal impairment, chronic kidney disease secondary to hypertension. And then the chronic kidney disease keeps on driving the hypertension. So that is another reason why. Okay, so good. This is how you have to think. So even when you detect the cause, if it is like too prolonged, you may be too late. So this is why in younger patients with hypertension, you have to actively look for a cause, because if you identify and correct the cause, it is curable. This is curable hypertension rather than treating for a lifetime. Okay, right. So if I ask you what is the commonest secondary cause of hypertension, that is, this answer is true. The commonest secondary cause of hypertension is actually primary hyperaldosteronism. Not many people believe this. So a lot of people think something like pheochromocytoma may be commoner. Okay, but no. Or otherwise known as Conn syndrome is the commonest secondary cause of hypertension. Okay, it is kind of more undetected, goes on very much undetected. So that is that. Right. So the next answer. Asymmetrically less developed lower half of the body can be seen in coarctation of the aorta. Like the body will be asymmetrical. The upper part is bigger, the lower part is smaller. Okay, surprisingly less number of answers. I thought you would be able to work this out. Okay, sorry, I was trying to see if I can find some photos online. It will take some time. Okay, so this is actually true. Because if you think about what happens in coarctation of the aorta, you will be able to work this out. Okay, so say this is like the commonest is congenital coarctation of the aorta now. Okay, so you have the arch of the aorta like this. Okay, and from the arch of the aorta, you have the branches going. Okay, so right side you have the brachiocephalic artery. Yeah, and then you have the left common carotid, and the subclavian arteries. Okay. Usually, coarctation of the aorta is beyond this point. This is usually where it happens. Okay, at about this point. So in coarctation of the aorta, what happens is beyond this, like the major vessels, your aorta suddenly becomes thinner, fibrotic and thinner. So what happens? The lower part of the body is perfused less. So as a result, the kidneys are perfused less. Okay, so your renin-angiotensin-aldosterone mechanism is activated. So you develop secondary hypertension. So that is what happens. In addition, now if you look at this arch of the aorta, you will realize that what supplies the upper part of the body? Like if you say, like you draw a, like you take a person and then above the nipple level. Okay, that means the upper limbs and the upper chest. What supplies that? Like what gives the blood supply is these major vessels that you're talking about. So say since childhood, the person is having a coarctation of aorta, they don't become symptomatic until like as young adults. Okay. So their like upper body will be nicely perfused. So the upper part of the body will develop normally. However, compared to the upper part of the body, the lower half of the body is relatively ischemic. Okay, so this is my stick man. Okay, so this arch of the aorta and the major vessels arising from the arch of the aorta will be supplying this upper half of the body. So from this point upwards, it will be supplying. So this part of the body will develop normally because the perfusion is okay, because you need food to grow. Okay, so the food will be there, it will grow. So your like development is normal. The lower part, the lower half of the body is relatively ischemic because of the narrowing of the aorta. So what happens is the lower body is asymmetrically smaller, comparatively smaller. Okay, so like this is this is a recognized sign. So in addition to the radiofemoral delays, particularly if it is a radiofemoral delay, not a radial, because if it is a radial delay, which means the coarctation has to be here. If it is the radiofemoral delay, which means the coarctation has to be beyond this point, somewhere beyond this point, which means the upper body is normally perfused, the lower body is less perfused, so the lower body is going to be less developed. Okay, so I hope you understood. Right. So, madam, is it like take time to develop collaterals? Yes, obviously, like yes, collaterals do develop. However, like remember here we are talking about the aorta. Like this is not about a blocked coronary vessel, so there are like collaterals, perfused in the rest, perfused in the rest. This is like we are talking about the aorta, which is like the biggest artery in the body. So, like, can all the collaterals put together take over the complete function of the aorta? I don't think so. So, like, just because you have collaterals only, like, you're not dead. You are still alive because the collaterals are there. These are the ones that cause the rib notching on the chest X-ray and all that, the collateral arteries, which will be like trying to compensate. But the compensation is not going to be 100%. Okay, so still this upper and lower body asymmetry is a recognized sign because of this, because collaterals are not able to 100% compensate for the coarctation. Okay, right. So next one. A 45-year-old female with skin psoriasis and psoriatic arthritis presents with a severe exacerbation of her skin lesions. She had recently been treated for an exacerbation of arthritis and was also started on some medication for newly diagnosed hypertension. Which of the following is possible to have caused the exacerbation of skin disease? So in other words, what I'm asking here is, what are the drug causes of worsening of skin psoriasis? Okay, right. Hydroxychloroquine. True or false? Anybody? Hydroxychloroquine, true or false? Okay, 2 people accepted the challenge and answered. 3, yes. Yes, those who got it right, good job. Yes, it does. Hydroxychloroquine is known to cause exacerbation of the skin disease. So this is one of the reasons why we avoid hydroxychloroquine in those with psoriatic arthritis. Okay. So if you can't remember what is hydroxychloroquine, this is a medication that we use as an anti-inflammatory and a DMARD, a disease-modifying anti-rheumatoid drug in a lot of autoimmune diseases, particularly in rheumatoid arthritis, as well as in SLE. So I told you we use this in rheumatoid arthritis, but in those who have psoriatic arthritis, we avoid hydroxychloroquine for this reason. It can cause very severe, dangerous exacerbation of the skin disease, a condition that we call erythroderma. Okay, it can be life-threatening. So HCQ should not be used in those with psoriatic arthritis. Next one, captopril. Oh, sorry. The previous question, the D and E I have missed. Okay, sorry about that. So in the previous question, we go back. His thyroid function should be evaluated. True or false? Thyroid function? I gave the answer already. Yes, good. It's true. I told you like hypothyroidism is a known cause of like secondary hypertension. So yes, you have to evaluate the thyroid function. Next, primary hyperparathyroidism is a known cause. Usually when it is given as a known cause, it means it's not a common cause. It's an uncommon but a known cause. Okay, one person answered. Okay, again, if you decided not to answer, I would say still good because this is like one of the difficult answers in this one. So it is true. Okay, it is a less common but a known cause. So particularly very resistant, like difficult to control hypertension in young people, they say check a calcium, check for primary hyperparathyroidism. It is a known cause. Okay. Right. So overall, with regard to this question, I would say the answers have been less forthcoming from you all. So the other questions you all are answering like more frequently. So there were like many people answering comparatively. So what I would suggest is that you go and revise your notes on hypertension because young hypertension as well as like just hypertension is a very commonly questioned area. Not unfairly so, because we would expect any medical officer these days to know about hypertension because it's such a common disease, such a common condition. So people have a lot of questions about them. So they'll come to you with the questions. So we expect you all to know at least the basics of hypertension. So which patients to screen for all these conditions and like what are the possible causes of young hypertension? What do you mean by young hypertension? So all these, yes, we expect you all to know. Okay. So I would highly recommend that you go and revise your notes on hypertension. Right? Okay. Right. So we'll move on to the next the question on the psoriasis. Then the second answer is captopril. So hydroxychloroquine, I said, is true. Captopril. True or false, Lamai? Yes, good. Captopril is true because captopril is an ACE inhibitor. So generally speaking, as a class, ACE inhibitors can exacerbate skin psoriasis. Okay. So that is true. Next one is diclofenac sodium. As a class, NSAIDs. Is that true? Okay, again, few answers, but surprisingly, this is also true. Okay. And some NSAIDs are known to exacerbate skin psoriasis in some people, not in everybody, but it can. It can. So this becomes a big problem because like psoriatic arthritis is a type of what we call spondyloarthritis. So the arthritis type is called spondyloarthritis. So at least for some of the groups, I have done a class on spondyloarthritis and I have told that spondyloarthritis is associated with something called enthesitis, particularly heel pain, posterior heel pain, like plantar fasciitis, Achilles tendinitis. So such enthesitis management usually involves treatment with NSAIDs. So like imagine a situation where you have to give the medication, but by giving it, you may exacerbate the skin condition as well. Okay. So this is one of them. It's kind of trial and error. So you can give and see whether it exacerbates the skin lesion. And if it does, you'll have to stop. Okay. But in general, NSAIDs as a class, so yes, they can exacerbate the skin disease. Prednisolone. Okay. 2 people got it correct. It's again very surprising. Prednisolone, yes, it can exacerbate. So particularly when you have like given them a course of steroids and then stop it, it can pretty badly exacerbate. Okay. So, okay, good question. Since diclofenac sodium is usually avoided in hypertension, can't we take the answer false? No, you can't, because usually avoided, yes, but then I have said that the patient was recently treated for an exacerbation of the arthritis as well. So like diclofenac is not absolutely contraindicated in hypertension. It's just we say with caution because like NSAIDs can increase the high blood pressure, but they are very commonly co-prescribed. Okay, because it's not contraindicated, just caution. And like given that the patient was recently treated for worsening of the joint pains, very likely that she was treated with NSAIDs as well. Okay, so no, you can't take it as false based on that. So as I said, now prednisolone, even though it's a treatment given for more like many rheumatological conditions, in psoriatic arthritis, you have to remember. So we do use prednisolone still, like even in psoriatic arthritis, when the arthritis is pretty bad, we need to control it. We do use steroids, but with caution. And after like explaining to the patient by giving this, we might be exacerbating your skin disease. Okay, it's a possibility. So last one is infliximab. I hope you know what is infliximab. Infliximab is called a TNF inhibitor. It's a biological medication called TNF, tumor necrosis factor inhibitor. Umangi. So won't prednisolone only cause worsening when it is stopped abruptly and not while giving it? Both are possible because like if you go through the lists of medications causing like exacerbation of psoriasis, you will find steroids there. So steroids can cause worsening while giving it as well as when stopping. Okay. Okay, good for those who answered. So it is true. Okay, this is again something very, very surprising because infliximab and then that class has has other medications like adalimumab and golimumab. So these are all TNF inhibitors. These are actually treatments, like very well recognized treatments for psoriatic arthritis as well as for skin psoriasis. Okay, so very refractory skin psoriasis, you treat with TNF inhibitors, even in the absence of arthritis. However, in like some patients, when you treat with like infliximab or other TNF inhibitors, the skin disease worsens. This is called a paradoxical phenomenon. So paradox is like something that goes against the expected, goes against the norm. You call that a paradox. So like looking at the pathophysiology, you expect the skin psoriasis to improve on starting TNF inhibitors, but instead it worsens. Okay, so this is called a paradoxical phenomenon with TNF inhibitors. So this is true. So at the end of the day, all 5 answers are correct. So hydroxychloroquine, captopril, diclofenac, prednisolone, and infliximab, all 5 are true. Okay, right. So this is, now I told you, sometimes there are questions that are purely recall. There is no way that you are going to work that out. You either know it or you don't know it. So this is one of such questions. Okay. And I have also told you, I will remind you now, if you come across a question where you don't know any of the answers, what should you do? Try to answer as many as possible. Okay, because negative marks are not carried over. But if you leave it unanswered, you are like bound to be like, you are sure that you are not going to get any mark at all. But say you like try at least 3 out of 5, you have chance of getting all 3 correct. Even if you get all 3 wrong, you are not losing anything anew. Okay, negative marks are not carried over. So do not leave best like true or false type unanswered if you don't know any of the 5 responses. Okay, right. Move on to the next one. A middle-aged male is noted to have aortic regurgitation. Which of the following is are true regarding his physical examination? So you might have guessed this was a patient that we gave for the exam this time. Okay, based on a patient that was given for the exam this time, and like looking at the way the people were doing the examination, I was like, oh my goodness, what have we told these people? Not everybody, there were some who did extremely well, but there were some who like didn't have a clue how to examine for aortic regurgitation, because the pulse gave away the diagnosis. You just had to palpate the pulse. It was like a very high volume bounding pulse, collapsing in nature. And some said collapsing pulse and the diagnosis is mitral regurgitation. And then I had to ask them, can you please tell me how you explain a collapsing pulse with a mitral regurgitation? And then they stopped to think. Okay, so this can't be. This can't be. So the first answer, an early diastolic murmur is expected in the aortic area. True or false? So I have given you the diagnosis. The diagnosis is aortic regurgitation. Do you expect an early diastolic murmur in the aortic area? See, you all know it. Then why do you come to the exam and do otherwise? Where do you get the murmur of early diastolic murmur of aortic regurgitation? You don't hear it in the aortic area. Don't look for the aortic regurgitation murmur in the aortic area. You don't hear it there. Okay, in the aortic area, the only murmur that you are going to hear is that of aortic stenosis. Good, left sternal edge, not the tricuspid area. This is above the tricuspid area. Okay, so tricuspid area is the lower left sternal edge. The aortic regurgitation murmur you will hear in the mid left sternal edge. Okay, it's about third intercostal space. Third intercostal space, left lateral sternal edge. That is where you hear the murmur of the aortic regurgitation. So we had students, some like coming and performing the maneuver, getting the patient to lean forward, breath held in expiration with the stethoscope nicely held in the aortic area. Okay, so they didn't have a clue as to what they were examining. So this can't happen again. So now be warned, this can't happen again. Okay, so the early diastolic murmur of aortic regurgitation is heard best with the patient leaning forward, breath held in deep expiration at the left sternal edge in the third intercostal space. Okay, the murmur will be accentuated in expiration. I already gave you the answer, so that is correct. Longer duration of murmur indicates a more severe lesion. By the way, why would the murmur be accentuated in expiration? So we say right heart murmurs are accentuated in inspiration and left heart murmurs are accentuated in expiration. Why is that? Did you know that right heart murmurs are accentuated in inspiration? Right. Oh my goodness, this is supposed to be a heart, okay? Yeah. Good, Kalana. During inspiration, venous return to the heart increases. Exactly, because like if you take this as the heart, this is supposed to be heart. This is the right side of the heart. Okay. So any murmur that is originating from the right side of the heart, such as tricuspid stenosis or regurgitation, pulmonary stenosis or regurgitation. So what causes the murmur? That is the other question. What causes a murmur? Okay, Damsara. In expiration, venous return to the left heart is high. I wouldn't really call that venous return. Okay, so whatever. Tell me what causes a murmur? Again, back to our plumbing lesson, okay? Yes, Kalana, good. That is what causes a murmur. So these are the two abnormalities that can happen in a vessel wall. Okay, so you have a normal blood vessel, which is the first one. And then the second one, you can have a sudden narrowing of the blood vessel. Or the third one, you can have a sudden dilatation of the blood vessel. Okay, so in the first vessel, the blood will go uninterrupted. It will just flow forward. The second vessel, it comes up to here, and then because of the sudden constriction of the vessel, there is a turbulence. This turbulence is what you would hear as a murmur. Or in the third instance, you have a blood vessel which suddenly dilates. Again, the normal flow is disturbed. You have a turbulence. Okay, so generally speaking, for you to get a murmur, there has to be a turbulence to the blood flow. Okay, and say like the stenosis. Now we talk about a stenosis. So the size of the stenosis or the surface area of the stenosis will remain unchanged. So if this remains unchanged, by changing what else can you increase the strength of the murmur? You can do two things. You can either, like say you hold the stethoscope here. To listen to this murmur, you hold the stethoscope here. To increase the murmur, to increase the intensity of the murmur, you can do two things. Either bring this like blood vessel, the narrow blood vessel closer to the stethoscope. That is one way. The second way is to increase the volume of blood flowing through this stenosed area. Okay, those are the only two ways in which you are going to increase the intensity of the murmur. So can you bring the blood vessel wall or the stenosis closer to the stethoscope? We do use this. Can somebody remind me, how do you bring this turbulence closer to the stethoscope during CVS examination? In the aortic regurgitation maneuver, you get the patient to lean forward. Why do you get them to? Yes, exactly, Riancia. You ask the patient to lean forward. And when you examine for the mitral stenosis murmur, you ask the patient to turn to the left lateral side. Why do you do that? So that the turbulent flow will be closer to the stethoscope, because your heart is a structure that hangs inside the mediastinum. It has a certain degree of mobility. So when the patient leans forward, there are like the root of the aorta, the aortic root comes in closer contact with the anterior chest wall. When the patient turns to the left lateral side, the cardiac apex comes to closer contact with the chest wall. That is what you do, the first instance. The second thing you can do is to increase the blood flow across the stenosed area or the turbulent area. Okay, so to do that, now right heart during inspiration. Okay, during inspiration, now how do you take air into the chest cavity during inspiration? Is by creating a big negative pressure. Okay, by the chest wall moving outwards, diaphragm moving downwards, you create a huge negative pressure so that air is sucked in from outside. Similarly, because your great veins, that is the superior vena cava and the inferior vena cava, they are so thin walled. So because of this very thin wall, changes in the intrathoracic pressure are felt very keenly by the big vessels, by the big veins. So when the negative, like when there's a negative pressure inside the thoracic cavity, your walls of the vein also move outward because there's a negative pressure. So if these are, say, the walls of the inferior vena cava, the walls will move outwards because there is a negative pressure. Okay, which means they can accommodate more blood. So from the lower part of the body as well as from the upper part of the body, this will suck blood in. So the right side of the heart will receive more blood during inspiration, right? Whereas in expiration, it's the other way around. Okay, during expiration, it's the other way around because the intrathoracic pressure now becomes positive. So the blood is squeezed to the left side of the heart. Okay, but the arteries will not really squeeze and reduce the flow because arterial walls are thicker. They are not really affected that much by the changes in the intrathoracic pressure. Okay, so this is why during inspiration, right heart murmurs accentuate, and during expiration, your left heart murmurs will accentuate. Okay, right. Next one. Right, longer duration of the murmur indicates a more severe lesion. The duration of the murmur. If the murmur is longer in duration, is the lesion more severe? Okay, again, there is a mixture of answers. A few of you got it correct. Okay, this is true. The longer the murmur, that means more severe the lesion. If it is an early diastolic murmur, that may be a mild to moderate AR. Whereas if there is a hollow diastolic murmur, which means throughout the diastole you can hear the murmur, that is a severe aortic regurgitation. Okay, the learning point here, there are certain things which we say if these are present, you can say clinically that the AR is severe. Okay, so there are certain clinical indicators to say that the aortic regurgitation is severe. And homework is going to be find these out because this was another question we asked from the students when this was given. Because the case was a very clear-cut aortic regurgitation. So we asked them, okay, how do you know, like, is there any way clinically for you to say whether the AR is severe or not? So questions like this, don't think you are going to fail because you can't answer, but if you are able to answer, you will get a better mark. Okay, so go and find out what are the clinical markers to say that aortic regurgitation is severe. Same goes for mitral regurgitation, MR. Okay, as well as for mitral stenosis. So these are the three like valve lesions where we commonly ask this question. How do you know clinically whether this is severe or not? Aortic regurgitation, mitral regurgitation, and mitral stenosis. So find the answer. You will find the answer in there are short case books. There are clinical medicine, like clinical examination books. You will find the answer there. But I beg of you, please refer standard textbooks. Please refer standard textbooks, not textbooks that are compiled by your senior batch or like your friend or something. There are enough standard examination textbooks and short case books in your library. Go to the library, find the books, please refer to a standard text. These are given. Okay. Next one, ischemic heart disease is considered a possible cause for aortic regurgitation. True or false? True. This is what people said in the exam as well. I would ask you, can you please explain how can ischemic heart disease cause like aortic regurgitation? You can't really explain because ischemic heart disease will cause mitral regurgitation, true, but not aortic regurgitation. If you say aortic regurgitation is caused by ischemic heart disease, that means you have no idea about the anatomy of these valves, how these valves open and close, and like what causes them to open and close. Because you get mitral regurgitation in ischemic heart disease because if you remember, the mitral valve leaflets are kept in place by something called the chordae tendineae, which are attached to papillary muscles. So during ischemia, cardiac ischemia, these papillary muscles or the chordae tendineae can rupture. So nothing to hold the mitral valve leaflet, it just flails away so that you develop a mitral regurgitation. But aortic valves are not like that. You don't have chordae tendineae keeping the aortic valve in place. It's a very, very fibrotic structure. Okay, so like ischemic heart disease is not considered a cause for aortic regurgitation. For AR, there are many other causes, like you can have collagen vascular diseases such as Marfan syndrome. You can have a congenitally bicuspid aortic valve. Then there are certain inflammatory disorders like ankylosing spondylitis, psoriatic arthritis, likewise. Okay, and there can be infective endocarditis, a much more common cause. Yeah, okay. Those are the causes, not ischemic heart disease. This is false. Next one, a family history of skin psoriasis is important in the history. I just told you the answer because like psoriatic arthritis can happen without really skin psoriasis, but having a positive family history of skin psoriasis may be enough. Because again, for some groups, I think I have told this, how does aortic regurgitation, or like why does aortic regurgitation happen in those with spondyloarthritis? Because spondyloarthritis is an enthesitis, which means wherever there is like fibrous tissue connecting one piece to the other, there can be inflammation. So aortic root, like what connects the aorta to the heart, is fibrous tissue. So it's an enthesis. So you get enthesitis there, inflammation of the enthesis there, and you get aortic root dilatation and as a result, regurgitation. Okay, so that is true. The last one. Okay, so the SBA type questions usually don't take that long, so we'll move on. A 56-year-old female complains of difficulty in walking. On examination, she has normal tone in the lower limbs. Distal muscle power is grade 3, while proximal muscle power is grade 4. Reflexes are diminished. There is cloving of the toes. Which of the following is the most appropriate next examination to arrive at a diagnosis? So send in the answers, please. What did you think this was? Good. The most of you, I would say, got it correct. Only few wrong answers. Okay, so the answer here is B. It's lower limb sensation. So going from the given examination findings, you should get that this is more to do with more likely to be a peripheral neuropathy. So this is very much likely a peripheral sensory motor polyneuropathy. Okay, so like why I gave here normal tone is deliberately because this was again a case given. And a lot of students mix this up because the patient had actually normal tone in the lower limbs. Okay, you can have normal tone where if you are very experienced, you will detect that this is slightly reduced tone. However, you may interpret that as normal. The main reason being the distal is more affected compared to the proximal. Okay, so when assessing the tone, you basically look at the knee, how the knee is moving. So you can miss subtle distal like hypotonias, you can miss. So take that as a normal tone, but still there is a distal weakness more than the proximal weakness. The reflexes are diminished and there is cloving of the toes. Everything put together, this has to be a peripheral sensory motor polyneuropathy. So the only way in which you are going to determine that for sure is by doing the lower limb sensation. Others are also true. Like, yes, you need to do an upper limb neurological examination to see, is this a length-dependent neuropathy? Are the upper limbs involved too? Yes, you need to assess the gait because even though the patient says difficult to walk, we don't know what is the difficulty like. So you need to assess the gait. Romberg sign, yes. So Romberg sign assesses the posterior columns. Yes, at one point you do have to do the Romberg sign. Then eliciting cerebellar signs. Anybody who says that they have difficulty in walking, you have to elicit the cerebellar signs. Particularly, there are certain cerebellar conditions where they can present with peripheral sensory type of neuropathy along with cerebellar signs. So yes, you have to do all this. However, I'm asking what is the next most appropriate step? The most appropriate is for you to first confirm that this is the sensory motor polyneuropathy. So what you need to do is lower limb sensation. Okay, right. Now I'm going to ask another question. If you get these findings, like such findings on the examination, before now, you know that when you go for the lower limb examination neurologically, you first do inspection, then you do tone, power, reflexes, then you do sensory. Okay, tone, power, reflexes, and sensory. So when you do the tone, power, reflexes, you get these findings. Tell me, how should you assess the sensation? Should you be checking for a glove and talking type sensation, or should you start with a dermatomal pattern of sensation in the lower limbs? So stocking type sensation or dermatomal pattern? Good. See, so when asked the question that way, yes, you know. But I didn't see a single student examining like that, the sensation. Everybody started going in a dermatomal pattern. So now you see, when it is put like this, so this is why every step of the way you have to interpret what you have gotten. While examining the patient, think, what did I get? What did I get? Which way is this progressing? Because if, when I tell you like this, so that patient clearly had cloving of the toes, clearly had distal distal power weaker than the proximal power. The reflexes were completely absent. So you are talking here about a peripheral neuropathy type, a low motor neuron type of lesion. So do not go checking for a dermatomal pattern because you can't tie the two together. It has to be a stocking type. So you have to come up in a stocking pattern to see where is the sensory level. Okay, it's not the spinal sensory level, it's a peripheral neuropathy type of sensory level. So a stocking type of sensory loss. Okay, so if you get that, yes, it's a peripheral sensory motor polyneuropathy. Okay, again, another word of advice. So some students could not do the sensory examination. You know why? Because after tone, power, reflexes, they were wasting their time on cerebellar signs because heel niche in test takes time. Okay, so when you like assess the lower limb coordination in the lying down position, the easiest to do is the heel niche test. That takes time. Okay, so they were trying to do that and they missed out their time on assessing the sensation. So this is like another reason why I gave this question. So now you have assessed up to this point. The next most important point is to assess the sensation, not the cerebellar signs. Okay, so you can adjust your examination accordingly. So by that point, if you think sensation is more important, do the sensation first before going to cerebellar signs. Okay, so now going through this question, you should realize why. Okay. Right. Next one. A 20-year-old man was referred for pink discoloration of his urine to the hospital. He had no previous relevant medical history. 3 days ago, he complained of a sore throat and was given a course of amoxicillin and ibuprofen by the GP, but those symptoms have resolved now. Other than discoloration of discoloration of urine, he is completely normal. On examination, he looks well. Blood pressure 120/70, temperature 36 degrees Celsius. Abdominal examination is normal and no organomegaly. Urine dipstick shows blood 2 pluses, protein 1 plus, nitrites negative. Serum creatinine is 62. I have given the normal range, so it is within range. So what is the most likely diagnosis? Answers, please. It is a bit of a reading, so that's why I gave you more time for this one. Only 3 people answered. It's okay if you get it wrong. Why I'm asking you for your answers is so that I can have an idea about how your thought process works. So that directs my teaching. That's why. Okay, I would say the good news is that you all have narrowed it down to the two most difficult answers. I would say the two most difficult to differentiate. So getting up to that point itself is an achievement because you have narrowed down the possibility, like the likelihood of getting an answer from 20% to 20%, you have gone up to 50%. Because 1 in 5, the chance is 20%. Now you have gone down to 1 in 2, which is good. Okay, so you have like reduced that crescentic glomerulonephritis is very unlikely. I would say the most important reason being he is otherwise completely well and the renal functions are normal. Okay, so in crescentic glomerulonephritis, this is always also called rapidly progressive glomerulonephritis. The patient will be very ill, will be in acute kidney injury, creatinine is going to be very high. Okay, so it's not crescentic. Is it vaginous? Okay, it could be, but then it's not the most likely diagnosis because the patient is again otherwise completely systemically well. Is that a cause of hematuria? Yes, of course. But he doesn't have any other symptoms. So that comes very lower down in the list. Can this be Goodpasture syndrome? Again, for those who cannot remember what is Goodpasture syndrome, it is also called the anti-GBM antibody disease, anti-glomerular basement membrane antibody disease. What happens is you develop antibodies against a certain protein found in the renal glomerular basement membrane, and you have similar antigens in your lungs as well in the alveoli. So as a result, you start bleeding from these two sides. So they come with bleeding from the alveoli which comes as hemoptysis or shortness of breath. And they can have, like, again, a type of like renal impairment along with hematuria. Okay, so this is not a good pasture syndrome. So is it IgA nephropathy? Is it post-streptococcal glomerulonephritis? The answer, the clue to the answer is in the third sentence, because it says 3 days ago he complained of a sore throat. That is where the answer lies, because everything else you cannot differentiate between IgA nephropathy or PSGN because they are identical. The patient is going to be otherwise okay. The blood pressure may be high or normal. Okay. They are going to have a nephritic picture. So the urine dipstick will show like blood plus or minus protein. The creatinine may be normal, may be elevated. Okay. But the clue to the differentiation is there in the sentence that 3 days ago he complained of a sore throat. Because post-streptococcal glomerulonephritis, so PSGN, is a reactive process. It's like a unnecessary and abnormal response to an infection. That's why it's called post-streptococcal. So you get a streptococcal infection, classically a sore throat. And after the streptococcal infection, your kidneys are affected by the immune system, attacked by the immune system. So for the immune system to attack anything, you need to develop the secondary immune response. So you know that secondary immune response, that is the antibody response, antibody-mediated response, takes about 7 days to start. Okay, secondary, this IgG-mediated damage takes about 7 days to start from the insult. So it's not 3 days after, 7 to 14 days after. 3 days, like immediately after an infection, what you get is IgA nephropathy. So those who have IgA nephropathy can get episodes of macroscopic hematuria following upper respiratory infections. If you go through a command clock, it will say that. Okay, so this can happen during the upper respiratory infection or like immediately after. But PSGN takes time, 7 to 14 days after the infection. That is the differentiating factor. Okay, so the answer is C, not D. Right, next one, a 70-year-old patient has acute onset marked dizziness and unsteadiness during walking. On examination, he has a left-sided Horner syndrome. There is loss of sensation to pinprick on the right side of the body and the left side of the face. What is the likely diagnosis? Good, I already have one correct answer. Can you send the answers, please? Good, it looks like almost all of you have gotten it correct. So can somebody tell me what is the commonly known name of this syndrome? There is a commonly given name for this constellation of symptoms. Good. Lateral medullary syndrome. So this is the classical description of lateral medullary syndrome. And the lesion is in the posterior inferior cerebellar artery, okay, which supplies obviously the lateral part of the medulla oblongata. Okay, so this is a brain stem syndrome. The lesion is in the posterior inferior cerebellar artery. So the answer is B. Okay. The last one, a 40-year-old woman presented for review of asthma. The current treatment was inhaled beclomethasone 800 micrograms per day and inhaled salbutamol as required via a metered dose inhaler. She used the salbutamol 2 or 3 times a day and woke up at night wheezing once or twice a week. What is the most appropriate management? In the sense, what is the most appropriate next step in the management? Okay, answer please. Okay, again, I don't mind if your answers are wrong. Just send in your answers so that I know your direction of thinking. Okay. Okay, so for this one, there's a bit of a mixture of answers. So there is A, B, and D so far. So now, mind you, so this is a patient who is already on inhaled like beclomethasone 800 micrograms per day. So this is a pretty high dose actually. So now beclomethasone we give as twice a day dose. So we give 400 in the morning, 400 in the evening. So that is already a pretty high dose. So doubling the dose is not really going to make much of a difference. So D is not the answer because now, like if you see here, the biggest problem is like she needs to use the reliever that is salbutamol 2 to 3 times during the daytime. And she also wakes up in the night wheezing. The main reason for this, like early morning symptoms particularly, is like even if you take salbutamol at bedtime, can somebody tell me the half-life of the salbutamol inhaler? Like once you inhaled, the inhaled salbutamol, what is the half-life? Or the duration of action? What is the duration of action? Yes, good. It's only about 6 hours. Okay. So say the patient goes to bed at 10 o'clock at night. Okay. So 10 o'clock, just before bedtime, the patient takes a puff of salbutamol, goes to sleep. 4 in the morning, she would wake up with again easing because by that time, the salbutamol has worn off already. And you know, due to many factors, asthma usually worsens towards the early hours of the morning. This is due to physiological changes during the sleep as well as environmental factors. So early hours in the morning is when asthma gets worse. So by the time she really needs the salbutamol in the system, it's already worn off. So what can you do? Ask the patient to wake up, like set the alarm, wake up at 1 a.m., take the salbutamol, go back to sleep. That can't be done. So you need medication with a longer half-life. By giving this, you can you achieve two things. One thing is these early morning symptoms are reduced. The second thing, you can reduce the requirement of the reliever during the daytime. Okay, so instead of using it 2 to 3 times during the day, maybe she can cut it down to only about once a day, the salbutamol inhale. So this long-acting beta agonists, this is the use, LABAs or long-acting beta agonists. So the answer here is salmeterol. So there were some who answered as A, montelukast, which is a leukotriene receptor agonist. Okay. So yes, LTR agonists can be used after trying the LABAs. Okay, so first you try a LABA, a long-acting beta agonist, which the answer given here is salmeterol. So first you try salmeterol, which is given twice a day because it has a pretty long half-life. Okay, so you can combine the salmeterol and beclomethasone, and like there are combined inhalers like that, salmeterol or formoterol, long-acting. You can give that once in the morning, once in the evening. Okay, so that is the best answer, best next step in the management. Okay, right. Okay, thank you very much. So can you again, before you log off, can you please send me the clearest point and the most difficult point for you to understand? So here, remember, the most difficult point for you to understand does not mean the question that you got wrong. It's the explanation that really didn't make sense to you. Any explanation that you found difficult to understand. Okay, so the best understood explanation and the least understood explanation. So if you can send that to me, I would be really grateful. Thank you. Okay, so there is a good question. So if there is an answer